Hey there, thanks so much for joining me. This is my general overview of the abdominal canister. We're going to be talking about what it is, why it's important, and the general checklist that I go through when I'm trying to deal with any pathologies relating to the abdominal canister. So let's get to it. So what is the abdominal canister? Well, it's a group of muscles and bones housed within the core that are responsible for, one, creating core stability. It's that nice stable foundation from which the rest of our body moves from or generates power from. Secondly, it's really important for managing intra-abdominal pressure. The most common or well-known application of using intra-abdominal pressure to our advantage for some people is holding our breath when trying to pass a bowel movement. So down to my last point here, the glottis or closing the throat here can really help stabilize whatever pressure is being created in that region. So let's talk about the different structures that are involved. So at the top, we have the diaphragm. Remember, the diaphragm does move. Along the front and the sides, we have the transversus abdominis or the TA, the internal obliques, the rectus sheath, and the linea alba. So if we look over here, this is a top-down view or a cross-section of the trunk. We're talking about the transversus abdominis, which is the deepest muscle, followed by the internal oblique layer, the rectus sheath that comes all the way across, and then the linea alba that's in the center here. Notice how the external obliques are not included in the abdominal canister because they do not go the full length and close off that can or that cylinder shape. In the bottom of the abdominal canister, no surprise, we have the pelvic floor and the pelvis, and then the back we have the spine and the multifidus muscle, so one of the deepest layers or one of the deepest stabilizers of the spine. So as I mentioned before, intra-abdominal pressure is key for optimal core function. If we don't have a strong base, it's like trying to operate a crane in loose sand, right? So you can imagine even running on sand is very challenging because there's nowhere to generate power from when your feet are sliding all over the place, right? So imagine, the pelvis or that core being that central foundation of the body, and our arms and legs are like those cranes. It's really challenging to move and create power when, things are a little bit loose. But what happens if we don't manage pressure or that intra-abdominal pressure, as I mentioned earlier? What can go wrong? So if we do have an issue with managing intra-abdominal pressure, we're looking at different sides of the same problem. In the front, it would look like a diastasis recti or an ab separation. Down below in the pelvic floor, usually a prolapse for those assigned female at birth, or an inguinal hernia for those assigned male at birth. And then in the back, we're talking about a disc herniation. So none of these are fun, but again, they all do have some relationship to intra-abdominal pressure, which is why this is so important, to understand the abdominal canister. The main goal is to make sure that the structures can, number one, distribute the pressure evenly, but also withstand that pressure during rest and during movement or during activity. So you may have a concern where it's actually a pressure distribution problem and or an integrity problem in terms of the tissues involved. So that's where we have to do a little bit more troubleshooting, which is what we're going to be talking about in the rest of this lecture. So that said, it's really important to remember that intra-abdominal pressure management is a dynamic process. We're not blocks, right? We're not made of, stationary objects. We need to be able to breathe, which moves pressure around, and we also need to move, right? So it's a balance between, being able to access the movements that we need to through everyday life, but also have the stability and strength to keep us nice and stable and keep that pressure well distributed and well managed. So we're going to go a little bit deeper into this, but just really quickly, let's talk about this figure here on the left. When we inhale, there's a downward movement of pressure. The diaphragm descends, the pelvic floor descends. So there's pressure going down towards the pelvic floor. When we exhale, the pelvic floor contracts, pushes that pressure back up, And then the breath leaves our lungs and comes out through our mouths or our noses. But again, envisioning that pressure moving up and down when we inhale, exhale. And then perhaps front to back when we're doing something like a cat-cow. So you can imagine that when we're in this arched position, there could be more pressure through the front of the tummy here. And then when we're in this arched position, there could be more pressure out the back, depending on how your body moves. But for some individuals, this can also lead to pressure down through the front part of the pelvic floor. We're going to talk about that later. But just to show you that there are a lot more nuances, a lot more players involved when we're talking about the abdominal canister. So when it comes to managing intra-abdominal pressure, there are three things that are within our control. The first thing being breath pattern, and then muscle function and alignment. As you can imagine, like in that last slide, breath pattern plays a huge role insofar as, which way we're breathing and how we're sending the pressure of the air into our bodies. Number two, muscle function, where is the strength? Where is the stability in our bodies, and where is there not strength and stability? And then lastly, but certainly, not least, is alignment. So thinking back to that cat-cow that we just saw, if we're not in optimal alignment, that can lead to pressure concerns or intra-abdominal pressure concerns. Let's do a quick crash course on normal breath patterns. So three major ways to breathe or draw air into our lungs. Number one, the one that we should be doing at rest, is diaphragmatic breathing. So this is belly breathing or Buddha breathing, as it may be known to you. We're just thinking of using the tummy to let it rise and really draw the air down, because it's the least taxing when our bodies are working efficiently. When we start to perform slightly more demanding activities, we're going to be looking at rib breathing or 360 breathing. So thinking of those ribs like bucket handles, opening up to the side and then coming back down. So notice how if you put your hands, just on the sides, for women, if you wear a bra, just where that bra band is, we're going to take a nice big breath and really think of allowing those ribs to expand sideways. And this should be separate from the third and final type of breathing, which is apical or shoulder breathing, right? So we should be able to access the ribs for, slightly demanding or somewhat demanding exercises before turning to shoulder breathing for highly demanding exercises. So one more time, when we're resting, ideally we're thinking of diaphragmatic breathing to be the most efficient, because the lungs are, somewhat pyramid shaped. If we can expand the lower portions, we're going to get far more air just because there's more lung tissue there, as opposed to way up here, where there's the apex, the apical breathing that we talked about. There's just not a lot of volume there, right? So we really want to expand and draw air where we're going to get the most gas exchange, and that's at the bottom. So let's move on. So let's revisit what happens with a normal breath pattern. We take a nice big inhale into the lungs when the diaphragm contracts and draws down. It pulls down on the lungs so that the lungs can create negative pressure and the air comes in. But the organ contents, when the diaphragm descends, the organ contents moves downward as well. And if the pelvic floor is cooperating and playing along, it should relax nicely to accommodate that increase in pressure. So when we exhale, the pelvic floor is going to lift. It's going to contract, pushing up against the organ contents. And at the top end, that diaphragm needs to cooperate and relax. So when it relaxes, the lungs naturally recoil and the air is now moved out through the nose and or the mouth. So inhale, pressure moves down as the diaphragm contracts, pelvic floor relaxes. Exhale, pelvic floor contracts, diaphragm relax. Okay, so that's how we want things to happen in a healthy belly breath or a healthy diaphragmatic breath. Let's talk about things that could be a little bit off, or the things that can, be a little bit different when we're talking about breath pattern. So let's talk about the common concerns that I see the most when I'm assessing someone's breathing. So number one is sucking in. People are trying to make their waist really small. So they're breathing in by, reducing the pressure in their, organs or their abdomens and moving the pressure up into their shoulders. So they're breathing from here. So if we're thinking of inhaling and moving the pressure up, when we exhale, what goes up must come down. That pressure is going straight down into the pelvic floor. So not great for someone that may have a prolapse, or it actually may lead to a prolapse, especially if you're accustomed to that heavy downward pressure and then you have like allergy season or, a bad cold and you're coughing all the time, right? So all that extra pressure going down can create issues for your pelvic floor. For some individuals, if their pelvic floor is really, really tight, that pressure still needs to escape somewhere. So is this, common for you? Perhaps your clients, you're seeing pressure coming out the front of their tummies all the time. Maybe their diastasis isn't healing because they're just constantly exhaling through the front. Or for some people, I've had clients tell me, Ellen, my back hurts every time I have a big sneeze or a big cough, right? And so those are sort of like little clues to tell you where you might want to look next. So again, number one, sucking in is super common, and we're going to make sure that we try to address that as early as possible. Secondly is compensatory use of apical breathing. So what I mean by that is people don't know how to breathe through their ribs. Instead, they're going straight to their shoulders, right? So not necessarily sucking in, but perhaps there's tension in the ribs that doesn't allow them to access that mode of breathing. And so they're left with apical breathing instead. Hinge breathing pattern, where instead of having a nice, 360 expansion all the way around the rib cage, they're only expanding through the front. So it looks like, maybe like an arching of the spine, or perhaps there's so much tension in their backs that when they lay down on the bed or on your examination table, there's quite a bit of space underneath their thoracic spine, right? And so I would definitely address any tension to allow them to settle back into a more neutral position and then learn how to access the ribs there. Asymmetrical rib mobility, to build on that last point, can also be a thing. So I'm not going to go deep into it, but because we have asymmetries in our chest wall, in our diaphragms, and our lungs, our heart is on the left side. So because of that extra accommodation there by the diaphragm and all of the other, cardiovascular structures, the left side of the ribs tend to be a little bit more flared. Sometimes if someone's had a fall, I've had a few clients tell me, I had a slip and fall, or I fell on the stairs, or something happened and I had a really big moment of trauma on my ribs. And so because they never addressed it, that side of their ribs can become more tight or chronically tight, leading to more issues in the ribs on the right. So I have one client, the left side of her ribs is sort of locked up from a previous injury. And so she has a history of constantly subluxing some of the ribs on the right side because the left side is just so, locked down. And then lastly, holding breath during activity, right? We don't want to hold our breath because then when we start to move, we don't necessarily have good control over where the pressure is going, right? So again, this is just a high level lecture, but I just wanted to bring these to your attention because these are a lot of the things that I do see quite commonly. So let's summarize everything we talked about in breath pattern in this little checklist. I love tables and diagrams and charts and all those kinds of things that help visualize information. I do hope this makes this lecture a little bit more digestible. So starting off with the breath pattern checklist, we're making sure that the diaphragmatic breathing at rest feels natural. I can't tell you how many people tell me, this is so weird, this doesn't feel normal. But truly, I think society has done a number on us when it comes to using that sucking in technique to shrink our waistlines. So, this is a great place to start. Looking at rib expansion, as mentioned before, we want to make sure that they're able to access the ribs. They have to be aware of the rib movement just to begin with, so that they can check themselves when they're off out in the world, not in front of your eyes. Third is rib breathing on exertion, right? So we want to make sure that the apical breathing or the shoulder breathing is only coming in when they're doing very taxing exercises, and the rib breathing is really something that is more natural for them to utilize versus coming up here all the time. And then lastly, when we're talking about the pelvic floor, is it playing along? Is it relaxing when it should and lengthening down with that inhale? So remember, diaphragm engages or contracts, pelvic floor should relax in tandem, right? And then of course lifts and engages with an exhale. So these are the main things that I'm looking at. Let's move on to muscle function. Okay, so what's required when we're talking about muscle function? I mean, I could go on about this forever, but again, this is meant to be a high-level lecture. We're talking about activation and strength at rest and during movement. Are the right muscles turning on at the right time? Eutonic muscles. What is their resting tone like? Are they really tight, right? So remember I said if the pelvic floor is really tight, it's going to create a lot of issues when it comes to distributing pressure evenly. If the muscles are really weak, so thinking of someone that is newly postpartum, perhaps those deep core muscles have just very low tone from being stretched out from pregnancy, that could be a concern as well. Anticipatory control, again, of the deep core, specifically the transversus abdominis, needs to be second nature. I've talked about this before in the other lectures, but we want to make sure that the TA muscle becomes automatic. It should be there before we even start to move. That's also true for the multifidus in the back as well. And then lastly, we want to make sure that we're looking not only at the abdominal canister muscles, but also beyond. So even though the abdominal canister is limited to, the diaphragm, the deep core here, the TA and internal obliques, and then the pelvic floor, and then the multifidus in the back, there are so many more muscles that can influence how these muscles behave. So we want to make sure that we're looking at those as well. Okay, so don't get overwhelmed, but I just wanted to share really quickly what my brain is doing when I'm examining the abdominal canister for somebody. So we are talking about these pink circles representing the muscle structures that comprise the abdominal canister. We have diaphragm on top, multifidus in the back, pelvic floor on the bottom, and then transversus and the internal obliques on the front and the sides. The white circles are the bony structures, or in this case, the bony aspects or features that I consider when I'm performing my assessment, right? So looking at alignment of the spine, the ribs, the pelvic inlet, of course, pelvic alignment when it comes to anterior, posterior tilt, pelvic outlet, and then of course the sacrum when it comes to the pelvic floor. So I did try to arrange them in a way where they did have close proximity to the other structures that they're related to. It's not perfect. I did originally think of drawing little arrows, but then I thought it would just get way too cluttered. So there was a lot of thought into how I arranged the circles, but it's certainly not perfect. Moving on to the green circles. So these would be the indirect or supporting muscles that still affect the abdominal canister. They're not the pink ones where they're the actual canister, but they still can create concerns when it comes to intra-abdominal pressure and the management of that pressure, right? So if we're thinking of, the ribs, right? The intercostals can create issues when it comes to rib mobility. Same thing with the lats, erector spinae in the back with the multifidus in the spine, quadratus lumborum. Piriformis, of course, is very much close proximity to the sacrum. Feet are kind of a little bit far away, but still, on the pelvic floor side of things. And that's discussed in the pelvic floor and lower extremity lecture of this course. The internal rotators, adductors, of course, when it comes to anchoring down the pelvic outlet, iliopsoas. So if you're curious about the adductors, that is in the deep core and pelvic floor lecture. And then, of course, pelvic alignment, we're thinking of, psoas and hamstrings and glutes. And then rectus abdominis is also, towards the front side of the body. So that's why that is over there, external obliques. And then, of course, serratus. So we want to make sure that we're thinking about, the indirect muscle structures and not just these pink guys, right? We have to look farther beyond. Little caveat, this list is not exhaustive. I mean, I could go on forever. There are probably a lot more nuanced relationships between these muscles and bones. But again, just a very quick overview of the main concerns that I tend to see in my work. So let's fill out the center column in our abdominal canister checklist now. We're talking about muscle function in relation to breath pattern. Can the TA relax with that inhale? Are we getting that nice belly expansion? Or is there a previous abdominal surgery, maybe a C-section that's stopping them from taking a big belly breath? Maybe an appendix removal from an appendicitis or whatever it may be. Is there a history of endometriosis, perhaps, where people have a lot of pelvic pain and they just don't want to breathe into that area? Next, we're looking at rib cage movement. So thinking of the muscles that are responsible for rib mobility or rib movement, I should say. The intercostal muscles and the obliques play a huge role. So we want to make sure that they're supporting this 360 breath pattern as much as possible. If it's confusing for you, I do like to think of the breath pattern part as more of like a neuromotor or sort of like an awareness piece. And then the muscle function is more of the mechanical piece when it comes to the muscles. And then the alignment would be the bony structures when it comes to that mechanical aspect. So moving back here, the ability to stabilize the abdomen to access rib breathing on exertion. So remember how I said rib breathing is there when the activity level or the intensity level increases. And that's because we need to make sure that the low tummy is stabilized by the TA muscle, the internal oblique muscles, because we want to make sure that the spine is held and kept safe while we are doing more challenging lifting or running or whatever it may be, but we still have to breathe, right? So can they do those two things? Can they stabilize the abdomen while freeing up the ribs at the same time? And then, of course, the shoulders shouldn't be turning on, or the shoulder breathing shouldn't be turning on before the rib breathing. And then lastly here, we're checking for pelvic floor tone and coordination, right? So can they actually get that nice lift on that exhale, or are they pushing down, right? What's happening with their breath pattern and when they contract? So when you ask them to do that pelvic floor contraction or that kegel, are things functioning how we would like them to? What is the resting tone of the pelvic floor like? So as I mentioned earlier, if it's really, really tight, it's not going to be very good at receiving pressure and distributing pressure, right? And sometimes, I just mentioned here, sometimes there can be a history of anxiety that can really prevent that as well. But that's a whole other course in itself. Let's move on to alignment. All right, so neutral alignment, a few things to keep in mind. Neutral alignment is supported or optimized when we have adequate deep core engagement or deep core support, right? When we're all, relaxed and slouchy, then of course our alignment is going to be terrible. But if we take a nice big inhale into our bellies and then exhale, that can help really zipper up and bring our pelvis and sometimes our lumbar spines into a more neutral position, right? So again, deep core support is really crucial here. We want to remember that neutral alignment is not just about the spine and pelvis, but goes from the top of the head all the way down to the feet. It can vary by individual. So what's neutral for one person is not going to be neutral for somebody else. So I say this to my clients all the time, just like, how our noses are different, our faces are different, our spines are also different, right? So we want to make sure that we're not sort of taking a cookie cutter approach to everybody, but just doing the best for that one person as able. And then, of course, neutral alignment will change over time. So as we change muscle function, as we age, as for some of us, as our spines change, I mean, I think if we're lucky to live long enough, we will see bony changes in our spines, in our joints. And so that will also affect what neutral looks like as the years go by. So when I'm assessing someone's alignment, these are some of the things that are going through my head. I'm not going to do a deep dive because, again, this is just a quick overview. But I'm thinking to myself, which muscles are overactive? Who's really quick to turn on and help and jump in? Who's underactive, right? Who needs to have a little bit of a nudge to work a little bit harder or turn on a little bit sooner? Are there soft tissue restrictions? So for example, like scar tissue, are there, previous surgeries that may have created weaknesses somewhere? Are there past experiences influencing movement patterns? So thinking of someone that has recovered from a frozen shoulder or a knee injury or anything like that, they may still be stuck in that protective or guarding habit, right? So for someone that is reaching into a cupboard, for example, if they have a fear of pain or previously it would hurt a lot, they may actually move from their spine to reach up instead of reaching an opening through the armpit. And so that can lead to an increase in pressure through the front of the abdominal wall. Is there an increase in, how is their alignment during activity? So it's important, as I said before, to see what someone's posture looks like, not only in standing, but also when they're going through their regular activities. So cycling, running, walking, whatever it may be. It's not just a, hey, stand there beside the wall and let me look at you. It's, I want you to send me a video perhaps of what you look like when you're running from each side, maybe from the back and the front, or when you're cycling if you have a stationary bike. Let's see what your posture is like and go from there. So if we look at the, just a regular road cycle, thinking of, as I mentioned earlier, that spinal flexion and extension, that cat-cow, what that does to pressure can be very, very relevant when it comes to assessing alignment. So lastly here, I'm just going to touch on the infrasternal angle or this rib angle. This is in the spine and thorax lecture. So we're looking for approximately 90 degrees here, right? So as I mentioned in the previous spine and thorax lecture, if we're not at roughly 90, we're not putting our diaphragm in optimal position to generate, force efficiently, right? It's very challenging because I want you to think of, those fireplace bellows. If you're trying to blow air into the fireplace and you're stuck open here, you're not going to be able to produce very much air. Same thing goes is for if you're quite narrow, it's really difficult if you're not going very far because your ribs are stuck, right? So, dealing with infrasternal angle or that subcostal angle is something that I do a lot with my clients because I do find, especially in the postpartum and pelvic floor population, it is something that can be improved. One thing I should mention is for a lot of my clients that have smoked in the past, because of changes in the lung tissue, they may have limitations insofar as closing that angle down, right? So because for those that do have a very long history of smoking cigarettes, it can be very challenging for the lungs to function optimally. And so they may be stuck a little bit open because of the loss of elasticity in the lung tissue. But just keeping in mind that we're aiming for 90, but we may not necessarily get there depending on their history. So if we're thinking of passive rib mobility, that tends to be where I start. Right? So I tend to check and see, okay, if I have you supine or lying down on the table and I have my hands on their ribs, I'll do a little squish on one side. If the ribs absorb that movement quite well, then great, you have some really great rib springing, really nice rib mobility there. But if the force tends to travel through to the other side, then I might think to myself, okay, this side of the ribs, there's something happening where it's not absorbing that movement because the passive mobility just isn't there. So if it's stuck, then I'm going to feel that force on the other side with my other hand. So again, someone lying down on the table, little check on one side. If I don't feel it on the other side, great. On the same side or other side, if I don't feel it on the other side, also great. But if it's traveling over, then I know something is going on. Same thing goes for, assessing the SI joint, right? We want to make sure that even though maybe it's the right SI joint, we're still assessing the left because things can travel across. Okay, focus. I tend to go on tangents, so I have to keep myself on track here. Looking at active room mobility, right? So this is where the intercostals and the obliques come into play, right? We want to make sure that we're addressing resting tone and we're addressing strength and the ability to isolate those muscles for that 360 breathing when we need that, increased support for higher level activities. If you are interested in learning more about that, there's a great video on YouTube here that I've linked from Core Exercise Solutions. And Sarah Duval, she's lovely. I've taken a couple of her courses, talks a lot about that. So I would definitely have a peek at that if this is a new concept for you. She does a great job explaining it. And then, of course, lastly, addressing tension from any other muscles that can be interfering. So back to the lats, for example. If they're really locking down the backside of the body, it can be really difficult for those ribs to expand posteriorly. So lastly, I'm going to give you a few quick cues that I use with my clients to help them find neutral when they're on their own or when I'm doing Pilates with them. So staying stacked is a big one that I say a lot. We're thinking of head on your neck. So this can apply to standing. It can apply to, prone work on the reformer. It can apply to just 4-point, like so being on hands and knees. Thinking of keeping that tongue up can also prevent that forward head posture, right? So if you try it and you slouch, it's a lot of work when your head is forward to put your tongue up on the roof of your mouth versus when you're in, better alignment with your head on top of your neck. Next, for a lot of clients that tend to have a rib flare, I cue them to think of, ribs on pelvis or ribs, shining down into the pelvis as opposed to, the ribs shining forward onto the toes, right? So where is your rib cage kind of aiming, right? We want it to aim right down straight into your pelvic bowl. Hinging at the hips or really wide sit bones and, tried and true. If I'm a little bit more crass, I'll say, nice flappy butt cheeks, relax your butt. Right? Think of sending your femur bones deep into your butt pockets. But again, I really do pick and choose whom I use that with or with whom I use that. Pretending you're a box lid closing. This is one of my new favorites. So back to the hinging for anyone that just can't connect with their glutes, or perhaps their spine is doing something funny when you're getting them to hinge. I'll say to them, pretend you're just the lid of a box, like a regular plain old cardboard box, and you need to close down and up. That seems to help a lot for some of my clients that tend to go into, an arched spine or lumbar lordosis or increased lumbar lordosis. Upright pelvis. So standing, sometimes people, again, might not quite be able to find neutral when it comes to anterior or posterior tilt. I'll say, okay, imagine there's a bucket of water housed inside of your pelvis. Let's keep your pelvis upright and not spill that bucket forward or backward. And then lastly here, gently hold an orange under your chin. I think this should have gone up top here. Anyway, we're moving on. So this isn't mine. I heard this through the Pilates grapevine, but I do love it because people tend to poke their chin forwards when we're doing exercises sometimes, especially on hands and knees, if we're doing any sort of like a supine mini curl up or something like that. So thinking of, gently pressing that orange down against your breastbone here without really like squishing it can help. And it'll prevent, again, that sort of chin poke. All right, home stretch. So we are getting into the alignment section of the abdominal canister checklist now. We're filling out this final area, remembering that these are all fluid, right? So we're looking for a nice, quiet spine with that belly breath. Sometimes people have such a hard time getting their heads around doing a tummy or a belly relaxation breath that they tend to arch their back, right? They're so intent on letting their tummy rise that they actually use their whole spine to make it go up, right? So we want to make sure that the spine's not moving. We want to make sure that the ribs aren't flaring out. As I mentioned before, we really want to make sure we're getting that nice optimal infrasternal or subcostal angle to put the diaphragm in a great place for optimal function, right? And that relates back to that nice 360 breathing, that nice fullness in the rib cage all the way around. Next, we're thinking of spinal alignment being optimal for whatever it is that they're doing, right? So we're checking for, as I said, forward head posture, any lordosis. Like this has to be in place for the core to function, for the rib breathing to happen. Hopefully that makes sense, right? So if you're trying to stabilize the core when you're jogging, right, it's ideal to have a nice stacked spine. It's nice to have that rib stacked over the pelvis. It's nice for these deep core muscles to have everything aligned so that they can function, so that the ribs can move. So hopefully that all makes sense to you. Lastly here, we're doing a pelvic alignment check. We're looking for anterior posterior tilt, pelvic inlet and outlet, internal rotation, external rotation, because we do want to support the pelvic floor. And then moving down into the femurs, what are the femurs doing? Do we have good positioning of the femoral heads? Are they sort of anterior in the socket? Are they internally rotated, externally rotated, right? So all of this is going to have an effect on what the pelvic floor is doing. And then also if we can get that nice relaxation with that breath pattern. All right. So I do hope that all makes sense. Take your time to digest it. You can definitely post your questions in the comment section of the course. But, as consistent with the rest of the lectures, nothing is perfect. We don't live in a vacuum. There are always things going on. These are some of the challenges that I do see when working with, again, abdominal canister pathologies. There could be pelvic floor tension, as I said before, inner thigh tension that's feeding up into the pelvic floor, altered rib or spinal alignment. So this could be scoliosis. This could be a previous fracture in the spine. This could be, again, a previous injury, altered hip function. If there's, again, something happening with the hips, maybe there's some sort of genetic abnormality there, then that can also pose a concern. If they have piriformis syndrome, that can also be a concern as well. Any back injuries or posterior chain tension is going to create hesitancy in certain movements. It's going to create, difficulty when it comes to building strength in the back part of the canister or just in the low back and the deep core and the multifidus area. Impaired deep core function, so thinking of the transversus abdominis and the internal obliques, right? So as I said before, if someone's had surgery, if someone's had, even if it's something like an abdominoplasty, like a tummy tuck, that can definitely impact deep core function. I can't tell you how many times I've seen clients post tummy tuck years later after surgery, and they can't belly breathe because they're just so tight in the front, right? So this can come from a lot of different things. I'm not going to, pigeonhole that one. Range of motion restrictions, which is a pretty obvious one. Maybe there's arthritis, rheumatoid arthritis, any other rheumatic joint concern, like even ankylosing spondylitis, that kind of thing, or any musculoskeletal restrictions in the chain. So maybe it's something like a collapsed arch in one of the feet, right? That can have an impact. Hormone changes, right? We know that changes in hormones can definitely 100% affect the soft tissues in the body. So not just the muscles, but also the fascia and the ligaments as well. Hypermobility syndrome, speaking of all of those structures, those soft tissue structures. So anyone with like hypermobile Ehlers-Danlos or Ehlers-Danlos, like EDS, I'm thinking of those people. Anyone that may not qualify with EDS but still have hypermobility can also present with concerns along the chain. And then, of course, abdominal or back surgery, right? So if someone's had a discectomy or if someone's had a fusion or anything of that sort, that can limit your progress, but it can also limit perhaps what your expectations might be for that client. Okay, all that to say, we're not robots, right? I worry that presenting all that information can generate a lot of fear or, concern about, am I moving correctly? Oh, but is it okay? I did this at work, or I was doing this when I was gardening. Is that all right? Well, we have to do the best that we can. And then of course I always tell people, I don't want you to push through pain. But if we try and keep in mind, the big areas of concern or the largest areas or largest things that we really want to work on, then we just start with those, right? So going back to the checklist, breathing is the easiest place to start if you're not sure, right? And then moving on to muscle function, and then moving on to alignment in that order. So breathing function or breath pattern can be the quickest thing to alter, followed by muscle function, followed by, sometimes alignment, depending on what the concern is, right? So certainly take your time. We're not going to be hard and fast with these rules. We have to respect that everyone is human and we're not going to be perfect. But I will leave you with a lovely phrase or a lovely piece of advice from Julie Wiebe, another physiotherapist. And she uses the phrase, blow before you go. So what that means is if you're exhaling on exertion, then you're removing the pressure from the system, right? If you're holding your breath and you're holding that pressure, and if you're moving, that pressure is going to be distributed around, perhaps in ways you don't want it to be. So if you're exhaling and you're blowing before you're doing your movement, then you're reducing the risk of any pressure mismanagement. Okay, so hope that makes sense. And thanks so much for joining me.